Clinical examination of the central nervous system. Coordination. The coordination tests in the upper limb seek to identify either impairment of cerebellar function or extrapyramidal defects, as in Parkinson's disease. So you test the test of cerebellar function cannot be done when there is severe weakness. Occasionally, severe joint position sense loss will give incoordination indistinguishable from cerebellar ataxia. If you ask the patient to touch the tip of his nose with the forefinger and then to touch the examiner's finger held about 2 feet from his face, and then to go backwards and forwards a few times. Normally, the alternating movements should be smooth, but in cerebellar ataxia, the movements become jerky, and the patient may overshoot the target as past pointing. Terminal intention tremor describes a tremor of the hand as it approaches the target and is characteristic of cerebellar disease. Alternating movements such as tapping one hand on the back of the other or alternating pronation supination movements of the forearm becomes jerky and irregular as dysdiadokinesia. So fine controlled manipulative movements of the upper limb are characteristically impaired in extrapyramidal disorders, but pyramidal defects may also lead to slowness and awkwardness in these movements. In the absence of signs of spastic weakness, an inability to perform nimbly discrete finger movements is suggestive of Parkinson's disease. So you ask the patient to touch each fingertip to the thumb in 10 and then repeat the movement, or to tap rapidly with the 4 fingers with the hand resting on the desk. The writing is probably the best test of fine movements in the right hands. Coordination tests in the lower limb must include tests of balance, gait, and stance of the examination couch. In Romberg's test, the patient is asked to stand with feet together and eyes closed. Impaired position sense in the feet or severe vertigo or cerebellar ataxia will cause the patient to sway. Tandem walking, that is heel to toe walking, will reveal minor degrees of ataxia of gait. On the couch, the patient is asked to place the heel of one foot on the knee of the other leg and then slowly and neatly slide it down and up on the front of the shin. In cerebellar disturbance, the heel will wobble off the front of the shin. Repetitive tapping movements of the foot may be impaired in patients with Parkinson's disease when no other deficit is noticeable in the legs.